Before we begin, I'd like to ask unanimous consent for Congressman Doug Lamborn from Colorado and Congressman Bill Posey from Florida to sit on the dais and participate in today's hearing. So without objection, so ordered. Good morning. Thank you all for joining us for today's subcommittee hearing on choice consolidation, improving the VA community care billing and reimbursement. This morning's hearing is a second in the series of hearings the subcommittee is holding over the next several weeks on several aspects of VA's plan to consolidate community care programs under a new and improved choice program. Last week we met to discuss eligibility for community care under the consolidation plan. This morning we're going to discuss billing and reimbursement being considered under the plan. The importance of VA's effort to consolidate community care programs and the impact that consolidation will have on the future of VA's healthcare system cannot be overstated. The VA simply cannot offer veteran patients across the country the health care they need without using community providers to supplement the care provided in the VA medical facilities. That is a fact that is becoming increasingly obvious and increasingly expensive. In fiscal year 2012, the VA spent $4.5 billion on care in the community. 4 years later, in fiscal year 2015, care in the community costs more than doubled to just over $10 billion. That's an almost unprecedented increase over a relatively short time period, and there's no sign of that upward trend will reverse itself anytime soon. With the budget submission that was released Tuesday, estimating a need for $12 billion for community care in fiscal year 2017. In order for that money to be well spent and for our veterans to be well served by it, the VA must be a willing, fair, and consistent partner with community providers around the country. Unfortunately, the overly bureaucratic, highly manual claims process that VA currently employs to reimburse community providers does not meet that standard. Despite aggressive oversight from this subcommittee and by individual members of Congress, community providers, both large and small, continue to report millions of dollars in past due unpaid claims. And my office continues to hear regularly from providers who would like to serve veterans, but they are hesitant to continue accepting referrals from the VA because it's so difficult for them to get paid for their services. My office also hears a lot of confusion and frustration from community providers about what they are supposed to be getting paid in the first place. Reimbursement rates vary wildly across the VA's multiple care and the community programs. In some cases, the VA reimbursement rates are lower than Medicare, which makes it difficult for community providers to accept veteran patients and keep their doors open. In other cases, VA reimbursement rates are higher than Medicare. This is an inefficient way to run a large hospital, much less the nation's largest healthcare system. So moving forward, the VA must automate and simplify the department's community care claims processing system so that community providers are reimbursed accurately and in a timely, transparent manner. VA must also honor the important role that community providers play in treating veteran patients by developing standardized reimbursement rates that are fair, competitive, and consistently applied. Multiple bureaucratic steps that only time rather than value must be eliminated. The stakes are simply too high for the VA to do anything less. Thank you again for being here, and I'll now yield to Mr. Takano for his opening statement. Thank you.
Thank you, Mr. Chairman, for calling this hearing on VA's future plan to improve billing and reimbursement practices so that providers in the community can expect prompt, accurate payments for services rendered to veterans in a community setting. We are all aware of the challenges that face the department in this area. Numerous VA Inspector General's reports, Government Accountability Office reports, and the recently released independent assessment all outline several problems that VA should and needs to address in order to ensure that proper billing and reimbursement practices are put in place and adhered to. The department is first and foremost a health care provider, not an insurer of care. Congress saw the need to address the wait time crisis that surfaced in 2014. The Veterans Choice Program was authorized as a temporary program to address that issue. Congress has now required VA to consolidate their numerous purchased care programs under one umbrella in order to become more efficient and less confusing for veterans, employees, and providers. The new Veterans Choice Program offered by VA in the Care Consolidation Plan is designed to do just that. Now that the wait time crisis has subsided, it is important to ensure the VA continues its mission of providing health care to our nation's veterans. It is important we remember that VA was built to provide unique medical services to veterans who suffer from combat-related injuries and illnesses. We know veterans feel that they get the best care at the VA. It is our job to make sure that the VA has the resources it needs to provide medical care services veterans need. We know the current claims infrastructure and claims processes are complex and inefficient due to highly manual procedures. VA lacks a centralized data repository to support auto adjudication. According to VA, there are more than 70 centers processing claims across 30 different claim systems. VA's system is a labor-intensive, paper-based process that results in late and sometimes incorrect payments. The Government Accountability Office reports that VA's expenditures for its care in the community programs, veterans for whom VA has purchased care, and the number of claims processed by the Veterans Health Administration have grown considerably in recent years. In fiscal year 2015, VA obligated about $10.1 billion for its care in the community programs for about 1.5 billion veterans, 1.5 million veterans. This is compared to fiscal year 2012, when VA spent about $4.5 billion on care in the community programs for about 983,000 veterans, about 50% less. The most startling statistic is that the number of processed claims for VA in the community program, let me say it again. The most startling statistic is that the number of processed claims for VA care in the community programs increased by 81%. Given this increase and the state of VA's information technology infrastructure, we potentially have a long, expensive road ahead of us. It will be no small task to fix this problem, and we must work together to get this right. Mr. Chairman, I am interested to hear from the department in more detail on how they plan to implement improvements, how much it will cost, and what they will need from us legislatively or otherwise in order for the plan to succeed. I agree with the American Legion that a strong, robust veterans health care system that is designed to treat the unique needs of those men and women who have served our country is what we need. Getting there in a timely manner remains to be seen. I look forward from hearing from all the witnesses today, and I look forward in the coming days to bring the best quality care to all of our veterans. Thank you, and I yield back my time.
Thank you. Well, joining us today on our first panel is Randall Williamson, the Director of Health Care for the Government Accountability Office. Gary Abbey, is that right? The Deputy Assistant Inspector General for Audits and Evaluations for the VA Inspector General's Office, accompanied by Larry Rankenmeyer, the Director of the Kansas City Audit Office, and Dr. Bali Yehia, the VA Assistant Deputy Undersecretary for Health for Community Care, accompanied by Dr. Gene Miliaccio, the VA Deputy Chief Business Office for Purchase Care. Thank you all for being here today. Mr. Williamson, we'll start with you.
Good morning, Chairman Benishek and members of the subcommittee. I am pleased to be here today to discuss our preliminary findings on VHA's efforts to improve the timeliness of its payments to non-VA providers when veterans access care in the community. The number of processed claims from community providers has almost doubled since 2012, and this sharp increase has overwhelmed staff at some VHA claims processing centers in terms of their ability to process claims in a timely way. In fiscal year 2015, VHA paid less than 70% of its claims from community providers within 30 days. In contrast, TRICARE and Medicare paid about 99% of their claims within 30 days. To make matters worse, VHA data overstates their timeliness because paper claims, which represent about 60% of the claims they get, are not always promptly scanned into VHA's claims processing system. Until this is done, the 30-day clock VHA uses to measure processing time doesn't start to tick. At one VHA claims processing center we visited, for example, we observed about a dozen bins of paper claims and medical documentation awaiting scanning, some of which were received a month before our visit. Community providers who participated in our study were frustrated with VHA for requiring providers to submit claims and medical documentation multiple times, paying medical claims late, and being unresponsive to repeated attempts by providers to contact VHA and resolve payment issues. If these timelines and poor customer service issues persist, VHA will risk losing the cooperation and participation of community providers as it attempts to transition to a future care delivery system that would heavily rely on them to deliver care to veterans. To its credit, VHA has recently taken steps to improve claims processing timeliness, such as hiring more claims processing staff to replace those lost through attrition and establishing productivity standards for them. However, VHA acknowledges that its current claims processing system is not sustainable and longer-term solutions are needed, including revamping archaic information technology systems. At the behest of the Congress, VHA is in the process of consolidating its various purchase care programs into a single program called the New Veterans Choice Program. To do so, VA has developed a broad consolidation plan, which it presented to the Congress late last year, to develop a robust network of community providers and streamline clinical and administrative processes. According to VA, implementing this plan will allow it to put into place a much improved claims processing system. As well-intentioned as VA might be, bringing this community care consolidation plan to fruition will require a Herculean effort on many fronts. The sweeping changes VA is planning will likely be costly and will require major organizational and structural changes and modernization of its IT systems. Achieving the objectives laid out in the plan will require strong leadership, careful and thoughtful planning, effective project management, and transparency and involvement with multiple stakeholders, including the Congress. The absence of these elements can have severe consequences. Our prior work has shown that some of VA's past attempts to achieve goals of similar magnitude have been derailed by poor planning, project management weaknesses, and insufficient oversight. VA's past failures to modernize its system for outpatient appointment scheduling, financial management, and inventory and asset management are stark reminders of what can happen if mega projects of this scale are mismanaged. These projects were canceled after investments of hundreds of millions of dollars, leaving VA with little to show for its efforts. To date, we have not seen a detailed blueprint and specific strategies for how VHA plans to successfully implement the major components of its consolidation plan, especially as it relates to the claims processing system. Such a blueprint should include an analysis of available options, estimated cost, staff resources and new systems needed, specific timelines and a critical path for achieving its objectives and key milestones, performance measures to gauge success and hold managers accountable, and a process to ensure transparency among major stakeholders. That concludes my opening remarks.
Thank you very much. Mr. Abe, Could you please go ahead, 5 minutes?
Mr. Chairman and members of the subcommittee, thank you for the opportunity to discuss the Office of Inspector General's work concerning VA's purchase care programs. I am accompanied by Mr. Larry Rinkemeyer, the Director of our Kansas City Audit Division. VA's purchase care programs are critical to VA in carrying out its mission of providing medical care to our veterans. Our audits and other reviews have reported the challenges VA faces in authorizing, scheduling, ensuring contractors provide medical records and supportive services provided. It has been challenging to conduct effective oversight of VA's purchase care programs because VA continues to make significant changes and additions to the program. For example, we published 4 reports on PC3 in fiscal year 2015 that reviewed the effectiveness of PC3 providing timely access to care. We had planned to review the timeliness and accuracy of PC3 payments this fiscal year after providing VA sufficient time to process a significant number of claims to make reliable findings and conclusions. However, PC3 was soon followed by the Veterans Choice Program. Nevertheless, we have started a quarterly review of paid choice claims in order to meet the Choice Act requirement to submit a report on the timeliness and accuracy of payment of claims after 75% of the almost $10 billion of program funds are spent or when the program ends in August 2017. This approach enables us to view the expenditure activity over time and helps assess whether VA's payment process is improving or worsening. In September 2013, VA awarded HealthNet and TriWest PC3 contracts. In October 2014, VA amended the PC3 contracts to include administration of the Veterans Choice Program. This is an important matter when evaluating VA's plan to align all non-VA care programs under the new Veterans Choice Program. Since HealthNet and TriWest have built their choice provider network upon the backbone of the PC3 network, there are lessons that can be learned from the series of reports we issued in fiscal year 2015 addressing aspects of VA's implementation efforts. Our 4 PC3 reports identified issues with inadequate processes for submitting timely authorizations, scheduling appointments, returning of medical documentation for continuity of care, and a provider network that lacks sufficient numbers and mixes of healthcare providers in the geographic locations where veterans needed them. Being a retired Army officer, I decided to seek care under the Veterans Choice Program. This was my first experience of VA healthcare. In July 2015, I visited my VA primary care provider, and he ordered medical services that were not available timely from VA. For the first month, I was told I was not eligible for the choice program. Then in late August, I was told I was authorized for care, and I would be notified of my appointment in 3 to 5 days. Months passed without a word. On December 14th, I received a letter from HealthNet saying that they had scheduled an appointment with a local provider. However, the appointment was for December 12th, 2 days earlier. This is what VA considers blind scheduling. So I was a no-show on HealthNet's records. I called the Veterans Choice call center, and I asked if I could call the provider to avoid another blind scheduled appointment. They said yes. I called the local provider and scheduled an appointment on December 29th, about 165 days or 5.5 months after my visit with my primary care provider in July. My experience is similar to the issues we identified in our PC3 and recent Veterans Choice reports. The obstacles I experienced are also similar to those that many veterans are calling in to our hotline, and most likely your local congressional offices. The complaints fall into the following general categories: program eligibility enrollment, the authorization process, appointments and scheduling, and veteran and provider payments. In conclusion, our recent work has shown that VA faces challenges in administrating its purchase care programs. while purchasing healthcare services may afford VA flexibility in terms of expanded access to care and services that are not readily available at VA medical facilities. It also poses a significant risk to VA and, more importantly, a great deal of frustration and risk to our veterans' health when adequate controls are not in place. Without adequate controls, VA's consolidation plan is at increased risk in not achieving its goal of delivering timely and efficient health care to our veterans. Mr. Chairman, this concludes my statement. We would be happy to answer any questions you or the members of the committee may have.
Thank you very much, Mr. Abbey. I appreciate you including your personal experience. Dr. Yahia, you're recognized.
Thank you. Good morning, Chairman Benachek and members of the subcommittee. Thank you for the opportunity to testify today regarding the department's plan to consolidate community care programs, specifically on our efforts to improve billing and reimbursement. I'm accompanied today by Jean Miliaccio, who's our Deputy Chief Business Officer for Purchase Care. And I'd like to take a moment and look forward to the discussions from some of the other panelists and their experiences and be able to talk a little bit about some of the improvements we're doing to address those. To start, community providers are critical to VA's ability to deliver timely and quality care to veterans. As a clinician, I personally understand the importance of these partnerships and often jointly care for veterans with community providers. To strengthen and grow these important relationships, VA recognizes a need to pay claims accurately and timely. For many providers, late payments have a major impact on the practice and may cause some not to care for our veterans. We know this is unacceptable, and it's particularly problematic in rural areas where the number of providers is limited. Late payments may also negatively impact our veterans by creating unnecessary financial hardships. That's why in our plan to consolidate community care programs, we are keenly focused on improving how we interact with community providers, including payment. I want to provide the subcommittee with an update on our progress since the June 3rd hearing related to claims processing and prompt payment. In the last 8 months, we have focused our efforts on improving people, process, and technology. So first, related to people, we filled 220 vacancies in 57 days, and that's 33 days faster than our 90-day goal. We also provided and implemented productivity and quality standards. Second, related to process, we have implemented real-time monitoring of claims to ensure that the oldest claims are paid first, and we're actively removing any unnecessary steps that may be barriers to paying timely claims. Third, related to technology, we continue to try to automate steps where we can, and for example, we removed the duplicate claims process, and now that's automated. These efforts have produced results. As of today, 81% of authorized claims are current, meaning they are within 30 days of receipt. This compares to 73% in June of last year. Some sites have improved more than others. So for example, in Louisiana, claims processing has improved from 69% to 96% in the last 6 months. This improvement is even more noteworthy, given the fact that we continue to experience tremendous growth in the claims volume. Last fiscal year, we processed roughly 17 million claims, which represents a 21% increase from the prior year. Even though we continue to improve in this area, there is still much work to be done to meet industry expectations. We also recognize that our choice contractors have not been paying timely and understand the frustration this has caused. We are actively working to address these issues with an eye towards removing any barriers in the contract that may slow payment. I believe that open communication is critical for these partnerships to work, and have made it a point to meet weekly with the executives from HealthNet and TriWest to talk about issues that we're discussing today. Getting these partnerships right is important for VA and impacts our relationship with community providers and the veterans that we serve. We are taking steps to improve community care today, but also looking towards the future, incorporating lessons learned from the current program and industry best practice. We aim to move towards a claims solution that is more fully automated. That's why in the recently released draft performance work statement, we include a specific section focused on claims processing and payment. Lastly, we take the recommendations from GAO and OIG seriously. We are closely monitoring the reports and working to resolve issues that are identified. However, we do need help from Congress to formalize VA's prompt pay standard, which will help us align with current industry practice, and then also help from Congress to change the recording of obligations to the time of payment so that we can improve our accuracy in terms of funding. These two proposals will address many of the deficiencies identified in both GAO and OIG reports. Getting provider payment is critically important. We look forward to continuing to work with veterans, veteran service organizations, yourself, and Congress, as well as we move forward. I appreciate the opportunity to appear before you today, and I'm prepared to answer any questions you or other members may have. Thank you.
Thank you, Dr. Ye. I now yield myself 5 minutes for my questions. Dr. Ye, I guess I didn't hear anything from you about some of the things that Mr. Williamson brought up, to tell you the truth, and that is, we have a plan to consolidate, all these different forms of community provider relationships. And, we haven't heard anything about how is that going to work? How are you thinking about it? What are the options? To me, it's kind of scary because right now there's 7 different ways to do it, which is complicated bureaucratically, but at least physicians then have a kind of a choice as to what they do and where they fit in. And when you narrow it down to one system, that's pretty important to get that one system right then. You understand what I'm getting at here?
Yes.
And, developing that system is going to obviously take time, but I would like to be involved in seeing what you're doing so that we can provide input. As you know, I took care of patients in the VA in multiple different ways and throughout my career. Sometimes it was very frustrating that we finally settled on a system which was equitable, I think, for the VA and for my practice.
Yeah.
One of the things that we wanted to talk about too is how we're going to set fair and competitive reimbursement rates for a physician. That's one of the things that comes to my mind as a provider. Can you talk about that a little bit?
Yes. When I talk to providers, just as you talk to providers, without doubt they want to care for veterans. And when I ask them kind of what stands in their way, one of the issues relates to payment, and that deals with what you just described. One is the reimbursement rates. Right now, under all these different programs, we pay differently. So under the traditional PC3 program, it's less than Medicare. Under the Choice program, it's up to Medicare. In some of our emergency room authorities, we pay 70% of Medicare. It's very confusing to community providers to know what they're going to get billed for, what they're going to get paid for. And that's actually causes some of the problems that we're experiencing today with prompt payment. A lot of folks are expecting VA to pay a specific amount, but we don't because they don't understand all the rules that are in place. So what we hope to do is move towards a standardized fee schedule. That fee schedule will, as best possible, be based on Medicare, which is kind of the common practice in the community. We know that some specialties we might have to pay a little bit more than Medicare, and in some locales, specifically rural areas, we might have to pay a little bit more. But for the most part, we want to try to move the system towards Medicare rates as best as possible. So that's kind of some of the efforts that we're hoping to do. The other thing that is important to recognize is that not everything has a Medicare rate. So for example, dental care, there's not actually a Medicare rate. And across our facilities in the VA, we pay different rates when there isn't a Medicare rate. So some of the work that we're trying to do is for those services that there isn't a fee schedule by Medicare, how can we come up with a regional fee schedule or a VA fee schedule so that folks know exactly what they will get paid for the services they provide? So that's a little bit of some of the work that we're starting.
Oh, where are you in this consolidation situation? I mean, do you have a blueprint of what you're going to do, like Mr. Williamson talked about? I mean, when can you show that to us?
So let me explain a little bit of where we are. So in the consolidation report that we presented, that provides a little bit of the overview, the blueprint, the direction. There's a number of things that we can do today, and so what we're doing is we're categorizing what are the things within VA's control that we can try to impact today. A lot of those have to do with like process improvements, removing unnecessary steps, but there's as we kind of talked about as well last hearing and in the plan, there's a number of things that we need to partner on to be able to do together. So being able to get to one eligibility criteria, as we discussed before, we can't do that. We need help from Congress. So there's a couple of things that are squarely in our field that we're trying to move forward, and then a couple of things that we need partnership with you to move forward.
Can you tell me anything specifically that you're doing as far as this paperwork requirement from community providers? I mean, apparently there's different criteria as far as what the provider has to do, depending on who they are, where they are, what medical center. Seems to be very variable. Can you just talk about that for a minute?
Yes, I'd love to discuss that, because the other thing that I was mentioning is when I talk to community providers, one is payment, the other one is paperwork. And it comes in two forms. When currently our contractors, as many of you know, there's a requirement in there that we have to get the medical record before we can issue payment. That is not an industry standard. That's not how other health insurance companies work. As Dr. Shulkin mentioned yesterday, we're in the final stages of being able to remove that barrier from the contract. I think that's going to go a long way to ensuring that we provide more timely payment. The other thing that we're doing is, as you know, we don't need every single piece of the record. I think back of when I was an intern taking care of patients, and I would get volumes from an outside hospital that I have to comb through to figure out what piece of information do I need to care for this patient. So what we're doing as well is defining exactly what are the important pieces that we need from providers. So that's the treatment plan, what new meds they started, what procedures and labs they did. We don't need every single nursing note or every single time a medication was administered. And I think that's going to reduce the paperwork burden. And so those are two things that we're working on today to make the lives of community providers a little bit better.
All right, I'm on it.
Thank you very much. Mr. Abe, you mentioned your comments about the risks posed by inadequate controls. Can you elaborate a little bit more what you meant when you in that part of your comments? What controls were you referring to?
Well, I think that there's a number of them. I think one of the things that VA has to do is effectively identify the veterans who are eligible for choice. The other thing is that they also need to sort of stabilize all these programs, because like the discussion has been that there's so many non-VA care programs, different eligibility requirements, different payment methodologies, and they have continued over the years to produce a pilot, another pilot, and another pilot, and so it's very, very confusing out in the field in how to pay claims, what veterans are eligible, but also I think the VA also needs to hold if they use contractors, they need to hold these contractors accountable to the contract terms. I think the biggest thing is, from the veteran standpoint, is that they need to minimize the veterans' requirements, that veterans have to jump through all these hoops to get this care. I think those are probably the major lessons and major obstacles that we currently face.
Okay. Where do, I don't know who can answer this question, but where do third-party administrators fit into the new Veterans Choice Program? Are you going to create your own high-performing network in-house, or how will the VA communicate with veterans using care in the community for their health care?
Sir, I'll take that question. The work we've been doing over the past, since we were here in June of last year, talking about prompt pay, and the hard work that we put together in terms of the plan that we delivered to Congress at the end of October, we have also stood up as a part of the plan something we call an integrated project team to focus on the future state. Looking at our patient-centered community care contract that we call PC3, we're looking for a follow-on contract. So what we're looking at in that contract is to look at high-performing networks, a claims solution, and other areas that we can support purchasing care in the community for our veterans. And I just want to give you a couple of examples. And we've been working at a brisk, fast pace. We stood up this group a number of months back. In December, we had met with industry. for an industry day. We presented a preliminary request for information, met with over 80 individuals representing 30 major healthcare entities in the country. From our meeting with industry, we developed, as Dr. Yahia had mentioned, a draft performance work statement that was released just a few weeks ago that will form and shape a draft request for proposal. We'll come back to industry very, very soon after, and then put a formalized request for proposal out in the next 2 months.
So you are looking for a third-party administrator?
That's contained in the draft performance work statement, yes, sir.
All right, I want to get to another question. I know you had a second example, but I want to get this question out there. The administration is proposing the creation of a fourth medical care account, medical community care. This account, estimated at $7.3 billion, would be funded out of medical services for fiscal year 2017, but is included as a separate request for fiscal year 2018 at $9.4 billion. What will the creation of an additional health care appropriation account mean in terms of the budget flexibility the Secretary has continued to call for, and how will this additional account better enable VA to meet demand and provide quality time of care to veterans?
I'll take that one. I think that account was required to be created as part of the choice law that was passed, so I think it was something that Congress had asked us to do. I do think there is value, though, to make sure that there is a specific, pot of money that's designated for community care. I think your point about flexibility is important, though. We should make sure that there is adequate flexibility, so if we need to use a little bit more community care dollars in one year, we can move from the medical services account to the community care account.
So, Dr. Maliacho, I mean, so you're not going to build this billing system in-house? It's going to be a third-party administrator that you're looking to work with?
So what we're doing is, in our draft performance work statement, our intention is to put out requirements. And so we say, this is what we want. We want to be able to have a system that pays on time, that is mostly automated, and we put that out in our draft performance work statement. What we're doing now is receiving feedback from industry to say, can they meet this requirement? So we're in that first phase to figure out, is there partners in there, is there partners in the private sector that can do this? I think they probably are. We just got to wait their responses to see if they can actually meet those requirements.
All right, thank you.
Dr. Rowe?
Thank you, Mr. Chairman. First of all, I applaud the VA for consolidating these 6 programs that are different. That makes it very, very hard to administer. There's no question. We've got different rules. Let me sort of lay out where I think the falling short has hurt the VA, like Mr. Abe, in trying to get care. I've said this 100 times. I've said it once in this hearing. I've made hundreds or thousands of appointments for people. It ain't that hard to do. And Mr. Abe could pick the phone up and call his primary care doctor and make an appointment in 5 minutes. I can do that right now while we're waiting. It's not hard. We've made it incredibly complicated, and he had to wait almost 6 months to get an appointment with a doctor that he needed to see, that his primary care doctor decided. The other thing that the VA has done that has really hurt in a group like my size, if we don't get paid promptly, we have enough cash reserves to survive that. If you're in a small 1 or 2 or 3 person practice, you cannot. And when the payments have been cut with Medicare down to really very low levels, when you have an ACA out there that's created an out-of-pocket expense that most people can't afford, $3,000 or $4,000 out of pocket, they can't pay the doctor, and then the VA decides not to pay the doctor, they're out of business. And that's why they don't want to see. And even the reimbursement levels, many of us are veterans, some are not. You almost never talk to a provider that doesn't want to take care of a veteran. I mean, they just want to do it for a lot of noble reasons. So my question I want to start out with is, why didn't the VA just use a system like the Medicare is doing? They paid us promptly, quickly. I filed a lot of claims last year during my wife's illness. Blue Cross and Blue Shield, they figured it out. They paid the hospital and the doctors very, very promptly. What's the big deal? Why can't you just do that?
I've been nodding my head when you were talking because I agree with what you're saying. Our team took a trip to one of the Medicare processing sites that processes claims to look at industry best practice, because I asked the same question, why can't we do that? And the more that I thought about it, there's a couple barriers that stand in our way. One is the technology piece, but as we had talked about, being able to partner with folks in the community that has access to those technology pieces, like some of the Medicare subcontractors, would address that. The other thing that is very convoluted is the fact that we have all these multiple programs with different eligibility. For Medicare, it's pretty crystal clear if you're eligible or not eligible. For us, and let me use the example of like ER care, we pay differently depending if it's service-connected or not service-connected. So it requires someone to look at the medical record to see, did they go to the ER and was it for a service-connected related injury? If it is, we pay a different way. If it isn't, we do something different. So I realized as I was going through this is that we have to get the eligibility piece right, which is what we talked about last week, because if we continue to have a complex eligibility system, even if we partner with the best performers in the private sector, they're still going to have problems paying on time because it's so complex. So I think it's kind of a two-pronged thing where we got to find those partners or in the technology that works, but we also have to do our part in partnership to simplify eligibility so it's not too complicated.
Let me ask this question. These claims are paid out of, what, 90-something different sites around the country?
Yes, sir.
And would you foresee a situation where one site would not pay one hospital to catch up the payments in another facility?
Say
In
that.
other words, here's one medical center over here, and here's another medical center, and someone's directed at the payment. This one's behind 3 or 4 or 5 months.
Yes,
This
yes,
one's
yes.
caught up. Would
Yeah.
you just direct all the assets over here?
Yeah, so that's exactly, yes. And so we're working on that right now. This is one of those things that I was describing about things that we can do that are within VA's control. Those 90 different sites, and part of the reason is claims processing used to be at local medical centers, and now a lot of it is under the shop of community care. So that's why there's so many different locations. Because they're in different locations, there's different IT security clearances that have to occur. They can't tap into one system. They actually have to get privileges to access the other system. I don't know why it's that way, but that's what it is. So what we're working now is with our IT partnership, and Laverne Council, who's the new Assistant Secretary for IT, her team is really helping us to give security access to the sites that are performing really well, so they can process the claims for the site that are performing not so well. We hope to...
My time's about up. Let
Yeah.
me just tell you the real world implications of that. Okay, I have a friend of mine who retired from his dental practice because there's always not enough dentists at a VA. He sees just VA patients. That very thing has happened where he works, so he doesn't get paid. So he's going to have to close his dental practice because of what you guys are doing to pay claims somewhere else. And that means that veterans where in a facility close to where I live are not going to get dental care. Sorry, I yield back my time.
Mr. O'Rourke, you're up.
Thank you, Mr. Chairman. Dr. Yahia, thank you for helping us better understand the plan and the proposal. And I want to begin by saying when Dr. Shulkin, you and the team first announced this in October, it was very encouraging, and I was very excited by the vision that you all outlined for the VA. It was comprehensive. It made sense of leveraging community capacity, and what I read into it was having the VA better focus on what I think its core priorities should be. But given the skepticism well earned by the VA that I hear from Mr. Williamson and Mr. Abe, and in Mr. Abe's case from his personal experience included, given the fact that you have 10 and a half months left, given the scope of these changes, and then again to bring up what I think is the most critical urgent priority, reducing veteran suicide, and the crisis that we have there that really will take concentrated focus for us to make a meaningful impact. What of this lift could you offload to someone else, either in the public or private sector? So to follow up on Dr. Rowe's question, if CMS has a 99% under 30-day pay rate, I know there are obstacles, and I know these are different animals, but is there a way to bust through that and contract this with CMS, who seems to have figured this out and has a lot of experience doing it right, or at least better than the VA? Is there some other part of the billing, reimbursement, validation process that could be outsourced to a private provider who does this really, really well. And we could set these benchmarks and standards. So that'll be my first question. The second one, a shorter one, can we get a copy of the draft performance work statement that you keep referring to? So my two questions for you.
Sure. So yes to the second one, and I think we sent it to the committee staff last week.
Great.
It's publicly available. And not only can you get a copy, but if you want me or others to come and walk you through it, we're happy to do that. And to your first point, that's exactly what's in the performance work statement. So there's a section in the performance work statement which is the first part of like an acquisition cycle. So as Jean was describing, it's kind of the first step, and then later on is the RFP and et cetera. So that's exactly what we're looking for. We're looking for who are those high-performing claims processing sites that potentially could, in the future, be able to bid on a proposal that we hope to do in the coming months, to be able to see if they can meet those needs. And so we are looking exactly at that option.
For Mr. Williamson, and if time permits, Mr. Abe, is within the 10.5 months, given the fact that we have VA's past performance as a potential predictor of future performance, but also given the fact that we have people like Dr. Yahia, Dr. Shulkin, Secretary McDonald, who really do seem intent on turning this around and have some success to show for that, is this realistic? Should we temper our expectations? What are your thoughts?
Well, I've been working with GAO a long time, and I have become skeptical in that time. And I've heard a lot of well-intentioned stories and whatever from agencies. I really doubt whether it can be done in 10.5 months. I think the IT challenges alone, I mean, VA on past IT projects where they've required modernization, the track record hasn't been real good. So, but I really appreciate their enthusiasm and their progressive attitude towards it, and they're moving out on it. I really think that's good, but realistically, it's going to be a tough pull.
Dr. Yahia, how much is the IT part of this cost? And then if time allows, I'd like Mr. Abe to comment.
I guess the point of this RFP, or the draft performance work statement, is to look for private sector, commercial folks that could do the work. So that is, out of all the different options, we're not talking about buying an off-the-shelf IT product.
How much will we have to invest in addition to what we're spending on IT today to make this work?
I'd have to get back to you on that number.
Okay. Yeah. Mr. Abe, any thoughts? I know I don't have a lot of time, maybe get additional
right.
15 seconds.
Just to summarize, I think I agree with Mr. Williamson in the sense that, you know, the IT solution is a real big obstacle, especially considering their past performance. The other area is that it really does take a lot of project management to do this. And again, I think in the past experience, that's probably been inadequate.
Thank you. Appreciate it. Thank you, Mr. Chairman.
Mr. Kaufman, you're recognized.
Thank you, Mr. Chairman. I think, well, whoever would like to answer this. I've heard time and time again from ambulance companies that VA misapplies the prudent layperson standard for emergency transportation. For example, VA has been requiring ambulance providers to wait for underlying emergency care claims to be processed and to provide medical documentation from the veteran's emergency room visit prior to processing the transportation claims. Although VA insists this isn't required, clearly the practice continues throughout the country, and veterans are often left with the bill. What is needed to correct the prudent layperson standard in the case of emergency ambulatory care? Who can answer that question? Yes.
I'll take it. You're spot on. The emergency system and the emergency ambulance part of the care system is challenging. That's why we wanted to tackle it and we did tackle it in our consolidation plan. The problem with ER care, which is what we spoke about a little bit more last week, is there's multiple authorities that we have for providing ER care. If it's service-connected, we are the primary payer. If it's not service-connected, we are the payer of last resort, so they first go to other health insurance, then us. It is, on top of that, being the difference in payers, we have different requirements if you were seen in the VA in the last 24 months. Did you bypass a VA on your way to the ER? And if the list goes on and on and on. I actually don't think it's the application of the prudent layperson is the biggest barrier here. That's a common practice in most health plans. It's all the other things that we have in place based on statute and regulation that we hope to consolidate and fix that. And that's what we present here. As you know, that comes with a little bit of a cost. We wanted to be able to streamline and get to being the primary payer and remove all those barriers. But that's exactly what we want to do. And we've drafted some legislative proposals that get at that. So we're happy to share those with you if you're interested.
Okay. Last Saturday, I spoke at a convention for ophthalmologists. There were about 400 in this Colorado last Sunday, and they and there were some VA personnel in there as well, docs as well, and everybody seemed to uniformly complain about HealthNet, and just how impossible it was to get paid. Is that the case throughout the country, or is this something endemic to Colorado?
No, that's the case, unfortunately, across the country. And that's why we are taking actions to remove those barriers. The biggest barrier in that area is the fact that we require medical documentation before we pay the bill. I don't know why that was in the contract. It was in the contract. When I first started this role a couple months ago, I looked at it as like, this doesn't make sense. No one else in the industry does this. We're in the final stages of finalizing that and removing that barrier. I think Dr. Shulkin mentioned it'll be done in 2 to 3 weeks. That's the time frame that we're working on. As soon as we get that done, we'll make sure that everyone is aware of that. The challenge is, when you get paid by Medicare or by a health plan, they don't ask you to give you the record. And this addresses a lot of the various issues that the IG and the GO found in the report too, of we're getting all these paper claims and all these medical records that we have to scan and do that. That's part of the reasons, is because we've been tying payment to getting medical documentation back, which is not a standard of care in the community.
Who devised this contract? Who's responsible?
This contract came about in September 2013, I think, or in the end of 2013, started implemented in the beginning of 2014. I don't exactly know. I don't know exactly what that was, who designed that contract. I will say one thing.
It was designed for the PC3 program.
Exactly.
And now it's being used on the choice program.
Yeah, and that's like a very important point as you raise, Congressman. That initial vehicle, that contract, was not meant to run the choice program. It was not designed to run a program like Choice, where we are sending hundreds of thousands of veterans into the community, expanding community care. That vehicle was not meant to do that. That's why we're moving out on this new draft performance work statement, getting a machine, a car that can actually run the race we want it to run. So part of it is it just wasn't designed to do what we want it to do.
Chairman, I yield back.
Thanks. Dr. Ruiz?
Thank you, Mr. Chairman. The damage veterans suffer due to the VA's current billing and reimbursement system is irreparable and unacceptable. A decorated Vietnam combat veteran from my district attempted to pursue care in the community for orthopedic issues and pain management. After navigating the complex and burdensome process of receiving care within his community, he was diagnosed with soft palate complications that would require surgery before other issues could be addressed. As he learned to treat and manage his neck and back injuries, he also learned that the VA refused to pay his medical bills in a timely manner. This delayed payment meant that the patient couldn't just concentrate on improving his health. He had to spend time worrying about his credit, as the clinic and later collections agencies hounded him for payment of his medical bills. Now, this veteran has damaged health and damaged credit due to the VA. The VA is meant to serve veterans, but it is clear in this instance that they did the exact opposite. They added a bad credit to a veteran who's barely making ends meet. This was a great disservice to him, one of our nation's heroes. So we talked about how the complicated system affects physicians and physicians' ability to provide that care. But how do your team plan, and this is to Dr. Yaya, how do you and your team plan to prevent this from happening in the future?
Thank you for that question. And, you know, I've been getting kind of similar letters too. And it's not the VA that's sending them to the collection agency. There's two things here.
No, it's the providers.
It's the provider.
But the
because we're
providers,
not-
as Dr. Rowe said, are hurting.
Yes.
And they're not getting payment, so they start to charge the patient.
Yes.
But the providers are under the expectations that they're going to get paid, and if they don't get paid, or if they don't get paid in a timely manner, then they charge the patient. So how are we going to prevent the providers from getting late payments? And two, what are we going to do to correct
Yes.
the bad credit for the veterans who already suffered the ill consequences?
You're describing it right. There's two things that we're doing. Number one, we got to get to the root cause, and the root cause of what we just described. The biggest barrier to prompt payment by our contracting partners is this requirement to submit the records. So we're getting to that basis. Once I think we uncouple or unlink those, it's going to be a lot better to be able to pay more timely and accurately. When I started hearing reports that veterans were getting adverse credit reporting, you know, I got very frustrated because there should be no administrative burden that stands in the way of them getting care. So let me tell you what our team did. We actually stood up folks in our call center. And so if a veteran has any problems with adverse credit reporting, we have a 1-800 number they can call. It's a VA folk. They can chat with them. We'll be able to connect with the community provider and our contractor, as well as a debt agency, to try to correct those. So I'm happy to give you that phone number if you want to share it with your constituents or put it on your website.
Go ahead and put it on C-SPAN right now. What is it?
I'll tell you, it's 1-800-877-881-7618. And I'm happy to provide it to the committee because it's unacceptable. And so we're trying to do what we can on our part to help veterans that have an adverse credit.
And what has been those results of our veterans? Have they eliminated that bad credit? Have they corrected the problem?
We just rolled this out a couple weeks ago, so I'd have to get back to you on kind of the results that we're getting.
Prior to the rollout, we have written letters to credit bureaus on behalf of our veterans. It is a travesty.
And what has been the results?
We have seen some good results because they have corrected credit reports, and I can get you some data on that also. I don't have specifics, but I'm told that we've seen some good positive outcomes. But we will intervene.
I would love to talk more about that because there are plenty of veterans throughout our country that don't even know what their resources are to remedy this problem. Many of our veterans just accept it because they don't like to complain, and that means that sometimes they can't apply for that loan to make home improvements. They have bad credit, so they can't pay rent in their apartment or other financial burdens. And so we need to outreach to make sure that gets remedied. So thank you very much.
Dr. Wenstrup, you're recognized.
Thank you, Mr. Chairman. If I can just add on to that, I would hope that we don't have to keep adding layers upon layers because layer 1 isn't being done. Now you have layer 2 of writing letters saying, hey, it's not this guy's fault. I mean, thank you for doing that, but that's not the answer, obviously. My next question is, what does the individual, the patient, the veteran do, and what does the physician do when these claims aren't getting paid? Is there a customer service branch that they can reach and have the same person to talk to when they call about the claim, either from the doctor's office or on behalf of the veteran, or are they just, because I've been getting reports that every time they call, it's somebody different and they have to start all over and wondering where this is taking place.
I think that's an area for improvement for us. To speak frankly, a lot of our claims processors also provide some of the customer service. What we're hoping to do is to kind of build a more robust customer service function for community providers. I don't know how the focus of those relationships has been in the past, but if you look at our consolidation plan and where we want to go in the future, we think about three stakeholders: veterans, community providers, and our employees. And maybe it's a little bit because I'm a clinician, I am very focused on making sure that we have robust provider relations and customer service for community providers. I think once we roll more of our plan out, this is going to be more localized, so that at the regional level, there'll be someone that they can talk to if they have issues, and then also kind of nationally, if they have just general information questions that they need, they can reach out. So I think we have more work to do in that area.
Well, I appreciate you acknowledging that, and I hope that it can be more fluent, if you will, but also hopefully less of a need for that. Again, another layer that could be reduced if we're doing things right. You know, you talked about the complexity of all the various eligibilities, and that's true. And I would throw out there, you know, sitting here, and you're involved with it. If there's ways that we can reduce that complicated process from this side of things, let us know what those are. You know, we'd love to hear from you on that, and I imagine you'll gather some ideas as you get more and more familiar with it, and I hope that you give us some feedback in that regard.
I welcome that opportunity. We definitely do have some ideas, and I'm looking forward to working with you.
But I do think at the same time there will always be some variables as far as eligibility, but it seems to me that an algorithm can be built. You're in this classification, you're in that classification, push the button and let the claim roll, because hopefully it's not that complicated, but if it is, give us the opportunity on this end to change things if we need to, that's fair to the veterans and gets the job done. And I don't know if you want to comment, if anyone else would like to comment on that any further. But anyway, when it comes to where you're headed, and there's a claim, there's usually a review of the claim when it comes from the provider. Do you anticipate, especially if you go outside the VA to process claims, do you anticipate the review to come within the VA or at that other claims processor?
I would, as best as possible, it would probably be outside, and this is how it would work. We want to create, the simpler that we can get, the better, which is, you know, more aligned with industry and Medicare. We would be able to, the way that I envision it working is with a partner. We'd give them the business rules. So we would want you to check the name, make sure the provider's address is right, make sure the bill charge was right, make sure they have the right eligibility criteria. So we give them the business rules, they put it into their system, and the way that it works now for Medicare and a lot of the other sites is, for the most part, it's green lights all the way through, a check is sent electronically, deposited in someone's bank account. That's where we want to go to. The more complexity that we add, whether it's we have to double check this because there's this eligibility in there, it makes it harder to automate every single step. So that's why I really welcome your comment to work together, because we definitely need to be able to get to a simple, streamlined eligibility criteria that makes sense, because those will form the business rules that we give to our partners in the community to process claims.
Thank you. I yield back.
Thanks. Mr. Hulskamp, you're recognized.
Thank you, Mr. Chairman. I'll try to arrive at that time again in the future. This is pretty quick, and I apologize for being late. It was another subcommittee hearing, and if I repeat some questions, hopefully it still provides some insight. But yesterday, visited with, I don't remember, whatever deputy undersecretary it was, said that we were going to see some changes, and paying before a paper claim would be required, and some changes there. Doctor, can you describe that a little bit more? It was a short part of the discussion of my questions yesterday.
Sure, and we have been chatting a little bit about that. What we were describing is the fact that in our current contract, there's a requirement that we have to get the medical information, the medical record, before we can issue a payment. And I was stating that it's different than the private sector. This is not a common practice in the private sector. This doesn't mean that we don't want records back, but we shouldn't penalize community providers in that way. And so what we're working on in the very near future to be able to kind of uncouple those, de-link them, so that we pay the claim when the work's been done, and then we still ask for the records, but not tie it to payment.
Yeah, and I appreciate that, and it was in less than 2 weeks. Is that the frame that? you
Yeah, it's the
predicted?
time frame we're working on, yes, sir.
Okay, okay. And if choice was made permanent rather than a pilot program, which some in the VA still approach it that way, the Secretary has said he would like to see it made permanent, and hopefully we can do that this year. Does that change that? Is that part of the reason that you want to have those records back? Describe that a little more, if you would, Doctor, from that
Sure.
perspective.
I think that was a requirement that was embedded in the contract. It was a kind of a contractual agreement that we had to hold, that folks had to be accounted to. I don't think there needs to be a specific, I don't think we have to get into that level of detail when we hopefully craft a new choice program by law. So I think it was more of a barrier that was in the contract than a barrier in the law.
Say that again, you think it's a contract, barrier in the law and the contract?
No, the tying the payment to the record was more a contractual barrier than a legal barrier.
And who made that request, though? The VA would make that request? I mean, I doubt the providers made that request. That was a VA request, is that correct?
We heard from our providers that they weren't getting timely, so we looked at why or weren't they getting timely, and the biggest reason was they had to submit all these paper records to us. And so we looked at our contract, and that was a requirement, and we're working on uncoupling it.
Describe why the VA wanted those records.
Oh, well, we want the records for care coordination. So if someone goes out into the community and gets seen by a community provider, and I'm their doctor and I come back and see them, I want to know what happened. So we want to get records back to coordinate care. We don't need every single piece of the record, the ones that are most important for the treatment plan, but it's important to get records for care coordination, but it shouldn't be linked to payment.
Yeah, absolutely, and I appreciate that. And fixing that, I have 70 community hospitals in my congressional district. I think as of 2 weeks ago, we were up to all those hospitals, plus another 1,300 providers, and they would like to continue and add on, but their goodwill is not going to run forever, and so we've got to fix that. And it's like the worst payer in the whole system is the VA, and I will be meeting with some of them next week. Be happy to say, hey, we're going to fix that. In 2 weeks, we'll have some changes. One thing, though, I want to point out that I thought was astounding was page 21 of written testimony. It said that processing centers still require providers to use fax machines to place inquiries about status of their claims. When are you going to get past the fax machine?
That was the whole idea of customer service, where I said we still have a long way to go. I actually had a conversation with the head of our customer service for community care, and I'd love to be able to discuss that a little bit more. We have, like I said, we have a long way to go to make sure that we're providing good customer service to our community providers, but we're focused on that. That's what we want to do. You should not send a question by fax.
Yeah. You might actually send their bonuses by fax and see how that would work, Doctor. So when will the fax machine be obsolete at the VA? I mean, when's this going to happen? I understand. I mean, joking aside, I mean, this looks silly, and if we can't move past that, we've got some deeper problems, IT problems. Describe, Doctor, so when are we going to have customer service that reflects the 21st century then?
I think it's something that's going to be, it's going to be incremental. So I don't have a specific time frame in my mind, but we're taking steps today to make it better.
Yeah. If I can give you a case in point.
Absolutely.
8 months ago, we were here, physicians could call in and check on their claims, and we put an arbitrary number on it. We said, you can only ask about 3 claims, and then you got to call back. And so innovative physicians, kept a number of lines going so they could continue their questions about their claim status. Well, after our hearing in June, we went back and we stopped that practice because it didn't make any sense.
Okay.
So, I mean, we'll take it step by step. As Dr. Yahia had mentioned, it's really evolutionary, but we want to get to a state where we can join that 21st century.
Yeah, and thank you, Mr. Chairman. I will say it's not evolutionary. This is a revolutionary change to the VA. And that's what I hope Choice does. And for my district, and everyone varies, but
You mean getting rid of the fax machine?
that could be considered revolutionary in some parts. So thank you, Mr. Chairman. I yield back.
Mr. Lamborn.
Thank you, Mr. Chairman. Thanks for having this hearing. I'm sure you were probably watching the discussion we had with Secretary McDonald yesterday. And one thing that I was and continue to be very upset and concerned about is the recent Inspector General's report on the problems in Colorado Springs. And whether we call it falsifying or just bad training and poor record keeping, there were people on the wait list who went way beyond 30 days. And yet the records did not reflect that. And it was not an honest record keeping. It was not a proper record keeping. And part of the problem is also veterans who are eligible for the choice program, which we're here today to talk about, were not put on that list of eligible veterans. And that was a big problem and continues to be. Now, the claim is that these have all been fixed in Colorado Springs. I think the jury is still out on that because we are still hearing reports of people falling through the cracks, and that simply should not be happening. In particular, I know that you've already discussed this today, and I apologize, I was in other meetings up until now, so I don't want to, sorry if I'm covering old ground, but we have people, providers in the community who are not being reimbursed on a timely basis. And I know this is anecdotal, but we have one provider in particular who has had to stop seeing veterans because he has not been paid for 6 months. Now, how, in this day and age, even if we're using fax machines, how can this be happening?
Yeah, I appreciate those comments. And if you give me the name of the provider, we'll have our team. We have actually created a rapid response team to work with providers that are having issues. So please give me that name and we'll be able to work on it. You know, we're doing like this two-pronged approach where we're driving towards the future, but at the same time we know there's problems in the current state, and so we're standing up and taking actions to address those. You know, I will say about Eastern Colorado, because I did watch the hearing yesterday and I did a little bit digging. They are in the top 5 in the country for utilizing choice, and so I think the idea. Yes, I think we need to do better in making sure that everyone understands how the program works. But when I looked at it, I was like, wow, they're sending a lot of people out in the community. And I think people want, when I spoke with the medical center director and the vision director, I think they want to see choice succeed in Colorado. And that, for me, was very telling, the fact that they are sending so many folks in the community. One of the things that I think I want to mention is you know, I looked at all these different reports that came out from the IG and GAO, and I think there's nuggets in there, there's themes in there that's important to put into practice. But as both of the co-witnesses here presented, this program has been evolving so rapidly. PC3 rolled out beginning of 2014. Choice, end of 2014. Got changed again in 2015. Those are only some of the law stuff. Continuously, we're making improvements on the program. So just imagine the level of training and really retraining that has to occur over and over again to learn new processes. We have not reached steady state yet, and in my mind that's good, because I don't want to be at this state. I want to be at a much higher state of excellence. But when I looked at the reports there, a lot of them had to do with, you know, training and system issues. And I think hopefully as we continue to evolve and get to a better place, we're going to be able to deliver the care that we need to deliver.
Doctor, I hope there isn't still a need, although I suspect there is, of a culture change, an attitude change, that there are those in the VA who simply are not comfortable or resist having the private sector be more involved in providing veterans care. And I know you all know this, but I want to say it for the record.
Sure.
It's true that there are a lot of veterans providing health care within the VA system. That's wonderful. But there's a lot of veterans, at least in my community, in the private sector who are providing health care. And they also have the similar motivation to want to do a good job for their former colleagues in arms.
No, I'm with you. I'm a clinician, and I practice at a VA, and then I've also practiced at academic hospitals and community locations and taking care of veterans. And I have a number of patients on my panel that I jointly care for with community providers. The fact is, last fiscal year, we had 1.5 million veterans, unique veterans that received community care. I think this trend is going to continue. I think we're going to, as we get a little bit better of level setting, what's going to be offered in the VA, what we leverage the private sector to help us with. When I talk to the doctors at the VA, a lot of them, it's their colleagues down the street that they're sending their patients to. So I don't know if it's a systemic culture thing. I think a lot of people welcome community of practice.
Well, I hope it's not. Mr. Chairman, I'm going to yield back, but we will get you the name of that provider. Thank you.
Mr. Posey, you're recognized.
Thank you very much, Mr. Chairman, and thank you so much for letting me participate in your committee today. Dr. Yeah, I hate to be redundant, but my concerns are very similar to those expressed by virtually every other member of the subcommittee. In my congressional district, we are already losing doctors because they've had such a bureaucratic nightmare trying to get paid. The physician's billing department is being told that it's something they did wrong, even when they make the required changes. It's as much as 5 months, and from what I've heard, my guys are lucky. It's only taken them 5 months to get paid. Can you tell me what's being done to shorten the time between billing and payment? And what I mean by that is, besides just saying this is what we're doing, can you tell me where it's been enacted, or if you've got rules that have changed that?
I don't want to sound like a broken record, but the biggest thing that we are talking about is coming in these next couple weeks, where we unlink the record from the payment. That, I think, is going to really speed up payment. And your district is in Florida,
East
right?
Central Florida, yeah.
Yeah, and Florida is dear to my heart because I grew up in Florida. I went to the University of Florida, and so I've read a lot of news articles about the hospital association and various challenges that Florida hospitals have been facing. Jean can describe a little bit about some of the work that we're doing with, specifically with some of the Florida providers to improve it.
Sir, some of the things that we're doing as part of this, as Dr. Hia had mentioned, the rapid response team, we have gone out and met with congressional staff members in local districts. We also work with hospital associations, state hospital associations, and we have been out to Florida, not in your district, but if you would like us to come out and talk to some of the hospitals, we'd be more than happy to do that. We provide a lot of provider education. We'll take cases back with us and start to work on claims. A lot of it centers in some of the accounts receivable. But, case in point, we spent a lot of time in Vision 16 in Louisiana and Arkansas, and we have seen some phenomenal changes, not only in terms of our paying our providers, but also working with our staff members. We pay in Vision, we call it Vision 16, Arkansas, Louisiana, about 96% of the time within 30 days of our claims, and we're just having phenomenal cooperation. By working with providers and their business staffs, it does make a difference, and we would do that for you too, sir.
Well, I would appreciate if you would come to our district and do that. Veterans who use Veterans Choice program, there are usually those in pain who can't wait for long periods of time, obviously, to get treatment. For instance, spinal surgery, knee, hip replacements, and things like that. Why are they getting paperwork authorizing the procedures that expire before authorizing procedures and care that expire before the paperwork is even generated?
On the authorization side, we've also made a change on that recently too, and that was, we gave an authorization out, it expired, it had a very short lifespan. That authorization was only good up to 60 days.
Yeah.
And that just didn't make a lot of sense to us. And with Dr. Hia, we talked about this when we created and drafted the plan that we presented to Congress in October, and we've extended that now in many, many cases up to a year.
Good, I'm glad to hear that. What percentage of employees that handle veterans health care have a military service background?
It's the number's about 30%, a little over 30% of employees in Veterans Health Administration that are vets. In our claims department, it's over 50%.
You know, I mean, when we hear from y'all, it sounds like everything's going to be quickly headed toward roses. And of course, y'all have been hearing that probably as long as you've been serving on this committee. But we get back in the districts, and then we seem to encounter claims people, for example, that don't seem quite frankly and simply to have much respect for our veterans. And I wonder if you've ever considered making prior military service a condition of employment, at least in those departments where it's point of service?
Let me take that. So I want to clarify one thing. We don't think this is a sprint. There are certain things that we have to get right today because there's such pain points, but we know this is going to be a journey to be able to get us to the ideal state where we want to be. I think what you're getting at is like military cultural competency training, and I think back to my medical training, and I never received anything specifically related to veteran or military cultural competency when I was trained to be a doctor. My only experiences were when I was a medical student working at the VA taking care of veterans, that I actually gained that appreciation and that respect. I think we could do a lot better making sure that our community providers have access to that sort of training, and we're actually taking steps to do that. We have 4 courses that are available online. People can get CME, Continuing Medical Education Credit, to learn more about the uniquenesses and the nuances of military and veteran healthcare. And so I think I'd love to be able to share those links with folks on the committee so you guys can push them out to community providers.
My thought is
your community.
Just respect for the customer, so they don't get the fast foot shuffle and the razzle dazzle. And I mean, somebody is giving them authorizations that expired before they got the paperwork. Now, nobody who respects the veteran that they're there to serve would do something that's stupid. And so my thought is maybe the claims people that process the claims actually ought to not get some kind of sensitivity training. Maybe there ought to be a requirement that they've had military service, that they have some respect for the job.
I think, as Gene said, half of them have served. I'd love to talk to you a little bit more about that.
I'm sorry, Mr. Chairman, I went over. I apologize.
Well, does anyone have any questions? One of the things that came up here, Dr. Yahia, and I just want to kind of reemphasize it, is the number of stupid rules that the VA seems to have which hinder the accomplishment of its mission. And that, simply removing one of the rules isn't going to solve all these problems. I mean, a comprehensive review of all your practices has to be done. So with that, go ahead.
I just am struck by, I just want to remind everyone at the committee that the VA was never set up to be an insurer and a payer. And so it is a revolution of sorts that we're undergoing. I mean, accelerated in the last 2 or 3 years. But you were set up mainly to be a provider organization. And the mindset has been that you're a provider organization. It's not that you have a bias against care in the community. It's that, the integrated health care that you provide was, the idea that you're getting the records back was all about making sure that we manage the patient's care. But now that we're looking at other approaches, and it looks like we're moving in the direction of maybe a permanent program of care in the community that's going to maybe expand over time, you're setting up the systems to do that and taking on more of the characteristics of provider organization as well as an insurer and a payer. So it was never really set up to be like Medicare, which is a payer organization. So let's make that distinction. And a lot of the beating up is the beating up on the department. It can be put into context. And so that's what I want to make sure we clarify, that you are undergoing this attempt to take on more of the role of a payer, somewhat of an insurer, and working with other partners.
Well, the panel is not excused. Thank you very much. Joining us on our second panel is Roscoe G. Butler, the Deputy Director of the National Veteran Affairs and Rehabilitation Division of the American Legion, and Carlos Fuentes, the Senior Legislative Associate for the Veterans of Foreign Wars. Appreciate you coming today, gentlemen. And Mr. Butler, you can begin when you're ready. Thank you.
Thank you. The American Legion is committed to a strong, robust veterans healthcare system designed to treat the unique needs of those who have worn the uniform. However, even in the best of circumstances, there are situations where the system cannot meet the needs of the veteran, and the veteran must seek care in the community. Chairman Benishek and members of the Subcommittee on Health, I am privileged to be here today and to speak on behalf of the American Legion, our National Commander Dale Burnett, and more than 2 million members in over 14,000 posts across the country that make up the backbone of the nation's largest wartime veteran service organization. The VA Purchase Care Program dates back to 1945 when VA's hometown program was created. Since then, VA has implemented a number of programs in order to manage veterans' health care when such care is not available in a VA health care facility, could not be provided in a timely manner, or is more cost-effective. Programs such as Fee Basis, Project Arch, PC3. Most recently, in 2014, the Veterans Choice Program was enacted so that more veterans could be referred outside the VA for needed health care services. However, it quickly became apparent that layering yet another program on top of the numerous existing non-VA care programs, each with their own unique set of requirements, resulted in a complex and confusing landscape for veterans and community providers, as well as the VA employees that serve and support them. Therefore, Congress passed legislation in July 2015 that required VA to develop a plan to consolidate existing community care programs, which VA delivered on October 30th, 2015. Generally, the American Legion supports the plan to consolidate VA's multiple purchase care programs into one new Veterans Community Program. We believe it has the potential to improve and expand veterans' access to health care. Most depend on how VA will work with its employees, Congress, VSOs, private providers, academic affiliates, and other stakeholders as they move forward in developing and implementing the plan. As noted in the plan, the current system is a decentralized and highly manual process. The new VCP plan proposes integrating most of VA's community care program into one single program that would be seamless, transparent, and beneficial to enrolled veterans. VA states its new VCP will focus on operational efficiencies to include standardized billing and reimbursement, as well as geographically adjusted fee schedules that are tied to Medicare and deemed appropriate. These efforts will make it easier and more appealing for community health care providers to partner with VA. The American Legion strongly believes VA must standardize its reimbursement rates, but not set the rates too low where providers will be discouraged from signing up as participating providers in the new VCP, such as providers in Alaska and other rural areas. In November 2015, we received an inquiry from a veteran requesting assistance with payment of a medical bill that was authorized under the current Veterans Community Care Program. The veteran explained that he was approved to be treated by a non-VA healthcare provider for a hernia surgery to perform outside the VA. After the care was provided, VA payment was delayed for months, which resulted in the claim being referred to an attorney office for collection. As a result, the veteran expressed disbelief and has lost faith in the VA system. This should never happen, but occurs more often than it should. The American Legion supports VA developing a 21st century claims and reimbursement process that is rule-based and, to the extent possible, eliminates as much human intervention as possible. Therefore, we are pleased to see that VA proposes to implement a claim solution which is able to auto-adjudicate a high percentage of claims, enabling VA to pay community health care providers promptly and costly, and to move to a standardized reasonable fee schedule to the extent practical for consistency in reimbursement. However, we do not believe Congress should continue to provide VA an open checkbook without any assurance from VA that the plan will work, much as further funding for the Joint electronic record is contingent on providing benchmarks are met. Congress can and should require progress benchmarks here. In conclusion, VA plans for the new Veterans Choice Program needs Congress approval. The American Legion believes the VA plan is a reasonable one, given that desired results. VA has identified a number of necessary legislative items that requires action by Congress in the short legislative window available this year in order to best serve veterans going forward in 2016. The American Legion support many of those, such as measures, budget flexibility, the Purchase Healthcare Streamlining and Modernization Act, flexibility for the federal work period requirement, and special pay authority to help VA recruit and retain the best talent possible to lead their hospitals and healthcare networks. The American Legion believes that together we can accomplish these legislative changes before the end of this session of Congress. We can't let another year slip away. Our veterans deserve the same sense of urgency now that Congress has shown numerous times since the VA scandal first erupted in 2014. The American Legion thanked this committee for their diligence and commitment to our veterans and as they struggle to access health care across the country, and I'm happy to answer any questions.
Thank you, Mr. Butler. Mr. Fuentes, 5 minutes.
Mr. Chairman, members of the subcommittee, on behalf of the VFW and our auxiliary, I would like to thank you for the opportunity to present our views on VA's plan to consolidate community care programs. The brave men and women who have worn our nation's uniform have earned and deserve timely access to high-quality, comprehensive, and veteran-centric health care. That is why the VFW has made a concerted effort to evaluate the VA healthcare system and has worked with VA, Congress, and other stakeholders to implement reasonable solutions to issues we have identified. In the past year, we have collected and evaluated direct feedback from more than 12,000 veterans. Through this work, we have identified several concerns with the Choice Program. Given the focus of today's hearing, I would limit my remarks to billing issues we have identified. The most common billing complaint we hear from veterans who use the Choice Program is that they have been improperly billed for their community care appointments. This typically occurs when a veteran is authorized to use the Choice Program, but requires follow-up care that's outside of the scope of the original authorization. This is where the program often fails veterans. At times, a veteran arrives to a follow-up appointment before the care is authorized, so the veteran is either required to reschedule the appointment or assume responsibility for the cost of that care. Most veterans reschedule that appointment and are forced to wait longer for the care they need. In some instances, a veteran arrives at the appointment and is unaware the care is not authorized. If the veteran's provider is also unaware of the authorization status or fails to inform the veteran may be billed for the cost of that care. For example, a veteran in Saginaw, Michigan, was also authorized to use the Choice Program for a vision exam. The provider prescribed him a specific treatment to save his vision. Since the provider was unable to administer that treatment, he was referred to a clinic nearby where he received 4 courses of that treatment before being told that VA refused to pay his bill and that he would need to pay his outstanding balance before he could continue to be seen. The VFW worked with HealthNet to ensure that that veteran could continue his treatment while we figure out a way to pay for his bill. Since his treatment at the clinic was beyond the scope of the original authorization, HealthNet did not have the ability to retroactively authorize the veteran's care. Luckily, we were able to work with VA to have his bill paid, but it shouldn't require our involvement to resolve this issue. That is why the VFW urges Congress and VA to empower local VA community care staff and the program's contractors to make common sense exemptions to Choice Program requirements to prevent veterans from being needlessly billed for care VA is required to furnish. The VFW also believes that it's time to fully integrate community care providers into the veterans' healthcare delivery model to ensure veterans have timely access to high-quality, comprehensive, veteran-centric healthcare without having to cut through bureaucratic red tape. The VFW has also learned that providers at times are responsible for improper payments or billing. The Choice program requires that payment be contingent on providers providing the medical documentation. Private sector providers are not accustomed to reporting medical documentation before receiving payment. As a result, some of them will bill the veteran before sending VA or the program's contractors the requisite medical records. To address this issue, VA has proposed decoupling medical documentation and payments. We are concerned that decoupling medical records and payments would remove the incentive of community care providers to share medical records with VA, which could impact VA's ability to verify the quality of care veterans receive. Ultimately, we will hold VA accountable for providing high-quality care to veterans, regardless if it's at a VA medical facility or through community care providers. In order to ensure that quality, VA needs that medical documentation. The VFW believes that this issue can be addressed without decoupling the medical documentation. For example, VA can develop IT solutions to facilitate a seamless integration of the healthcare records between medical facilities and their community care partners. This would prevent community providers from having to PDF or fax medical records to VA and ensure that VA can verify the quality of care veterans receive. As this committee continues to evaluate the VA's plan to consolidate community care programs, the VFW will continue to ensure veterans' preferences, healthcare needs are prioritized. Mr. Chairman, this concludes my remarks, and I'm ready to answer any questions you may have.
Oh, thank you, Mr. Fuentes. I yield myself 5 minutes for questions. And let me just comment about this medical record thing, and I noticed in your written testimony that you had that position. But, you know, as a provider myself, you can't be responsible for, you know, like the hospital medical record may not be your medical record, and the physicians get delayed. Now, there's certainly a reasonable requirement that if the physician has a habit of not returning any of the records, you know, he should be reviewed as a provider, and then, you know, maybe eliminated as a provider if he doesn't do medical records. You know, in private practice, physicians are responsible to get the referring doctor the pertinent records all the time, and they do it. And if they don't do it, then the people don't refer to them anymore. You know, that's just a better way, in my opinion, as a provider, to make sure that that continues as we go by. Now, you heard Dr. Yaya talk about improving the process, and I don't know if each of your organizations have any position on, would you be supportive of the VA moving to a Medicare model or a TRICARE model for payment and using you know, contractors to do that sort of thing? Would your organization support that? Mr. Butler?
I can speak for the Legion. We don't have a position on that. We haven't been asked to consider that as an option at this time, but we can take that up and look at that at a future date and bring that back to the committee.
Mr. Fuentes, do you have any position there?
Mr. Chairman, to us, it doesn't really matter the vehicle that's used. Really, what we want to prevent is what happened in Phoenix at the urology clinic, when hundreds of veterans were sent to community care providers, and VA had no way of seeing if those veterans received care or if they received the proper care. So, like I said in my statement, we are going to hold VA accountable for veterans receiving that high-quality care, and VA needs that medical documentation. The vehicle they use, you know, it doesn't matter to us as long as they're able to guarantee that care.
Right. Are there any particular issues that you haven't talked about that your membership is sort of interested in? I mean, to me, it's a real worry about how this is going to actually work out. consolidating all the aspects of care into one thing and having it work. So that's a real concern of mine. Is there any other things that you didn't bring in your testimony that you all are concerned about?
I think similar, like the comment expressed by GAO, we have similar concerns. This is a huge and tremendous undertaking, and VA's track record has not been good when you look at trying to take a system and then develop the IT changes necessary. The VA talked a lot about bringing in contractors to see how they're going to deliver a product. Oftentimes when that happens, when we look back at the scheduling redesign, when we look back at core FLS, VA spent millions of dollars in those type of initiatives, which was a huge IT network undertaking without any deliverables.
Yeah.
And so we don't want the same thing to occur. And that's why in our testimony, Congress needs to get some assurance from VA that they're going to be able to deliver whatever the changes that they're saying they're going to be able to implement. They need to provide proof that they can deliver those changes first before you commit millions of dollars.
I agree. Your benchmark idea makes a lot of sense. One of the concerns I have with the third-party pay or the provider, or the outside provider, is that what are they going to? They're going to cut any of their staff now if they have these outside providers doing a lot of the work. Does that mean that they're going to need less people in the VA, and is that going to actually happen, or are we going to have two bureaucracies? You know what I mean? That's my. Are we have paying for two bureaucracies instead of one? So, I have a lot of concerns about how this is done as well, and it's such a big project. It has a lot of scariness to me. I'll yield back, Mr. Decano.
Gentlemen, so the VA as a provider historically has had, I think, an interest in managing patient care in-house. From what I can tell, over the last several years, it's initiated a number of contract programs to be able to refer patients out when they didn't have certain services in-house, whether it was OBGYN or certain specialties. But now we seem to be at a point where we've authorized a temporary program that the Secretary is now saying that he'd like to see permanent, which is the Choice Act, which was initially conditioned on how far you lived away, but that seems to all be. Now we're looking at consolidating all these care in the community programs, all these different contract programs now. And Chairman Benishek, asked you your comfort level with this idea of becoming more like Medicare. Medicare, as you know, is not like the VA in the sense that it doesn't have, its own hospitals, its own doctors. It's a payment agency, right? Is that what your two organizations kind of are comfortable with moving toward? When he says Medicare model, that VA maybe is less and less an institution that has its own doctors and is going to contract everything out, and it's kind of like we're more a payer agency?
I can tell you that the American Legion position has not changed, that we believe the VA is a system worth saving. We advocate that. We supported the Choice Act as a temporary measure to allow VA time to get the resources, the doctors, and the necessary staff necessary to care for our veterans. So our original position has not changed from our initial position, that we support the Choice Act as a temporary measure until such time as VA can be able to provide the care and service to veterans. We know that community care, there will always be a need to refer veterans out in the community, but there also will be a need for the VA system.
Mr. Fuentes.
The VFW opposes, making VA simply a payer of healthcare. We feel that VA delivers high-quality healthcare, and unfortunately, it can't deliver timely access to that high-quality healthcare all times and everywhere. So you need to integrate the community or community providers into the veterans healthcare system. However, you need to eliminate that barrier that currently exists between the community and VA, where VA providers or VA facilities see the community as a safety valve, right, to alleviate the pressure on its demand. Instead, it needs to assess the demand and evaluate the capacity, similar to what Congressman O'Rourke has done in El Paso, assess the capabilities of the community and VA to really determine where those services need to be provided and what the true demand is, so that VA can focus on the areas the community lacks.
We're not talking here about this question about reducing personnel in the VA because it's now being taken up outside the VA. Your organizations aren't interested in that. Is that correct?
That's correct.
That's correct.
The Secretary has used language that has said, that he's interested in making choice permanent. That's what I've heard, being said is, so you still envision the choice program as something that should be temporary? Because this question about how much money we're going to spend on IT systems to make VA a more efficient billing, more efficient at paying, we can justify that based on what kind of VA prospectively we're looking at. I do believe we should be paying people more efficiently and taking away the bureaucratic problems in terms of whether we require them to get the records back before they're paid. But the question of how much we invest in this, I think has some relationship to what kind of VA we're looking prospectively at.
So I think the problem here is that you consider community care, and I think everyone's considering community care and the choice program as something completely separate from VA. When moving forward, community care and community providers need to be an aspect of the system. They need to be incorporated into it, and honestly, VA needs to treat providers who participate in their high-performing network like they would any other clinic within a VA medical facility.
Okay, thank you. My time is up,
and let me just add, community care is never going to go away. It has taken the form of many names: hometown program, fee basis. There's always going to be a need for community care, but there is also going to be a need for the VA healthcare system. And so there needs to be a balance between the two. One can't replace the other. They have its place in meeting the needs of our veterans.
Thank you for clarifying your position. Thank you.
Dr. Rowe.
Thank you, Mr. Chairman, and thank you, Mr. Butler and Mr. Fuentes, for your service to our country. A couple of things. I totally agree with Mr. Fuentes. What I have said for a long time is, as a veteran physician, served in the 2nd Infantry Division, I understand the needs, I think, of VA, of veterans. And why couldn't I be a veteran certified physician out here, but my bricks and mortar off campus? You're absolutely right. And I couldn't agree more with that. There is a difference between the VA and private practice. In VA every year, we appropriate billions of dollars, and they got a big pot of money. January 1 every year in my practice, I have no money. So I've got to generate that income to keep my bills paid. And the last person to get paid is the doctor. Everybody else gets paid before that. So when the VA is holding up their payment, and every other system in the world pays differently than the VA does for outsourced care. Medicare does, private payers do, they all do. We can assure, and just to show you how the payment models have changed, I was very deeply involved, as Dr. Benishek was, on the SGR reform. Medicare now requires us, and on the private side, to pay for performance and outcomes. And so the private sector is already ahead of VA in paying for that quality of care. So I agree with you. I think there are, Mr. Butler, I think there are going to be two systems. I think that the VA should embrace the private sector and identify quality physicians that provide quality care, and they're out there, and they want to provide the care. and then find a timely way to pay them. And then, as Mr. Fuentes is saying, is to make sure that the quality of that care is as it should be. I agree with everything that's been said, and I think what we have to do is make this easier so Mr. Abe, when he needs to get an appointment, doesn't wait 6 months. I mean, he gets an appointment in 3 weeks or a month or whatever his time, whether his schedule shows. So I think that's what we need to get to. And I think we're all aligning up, going in the same direction. I agree with you. And at home where I am, we have a very robust private sector. Many veterans out there, physicians who want to see patients. I'm in a group that had in an OBGYN group that had 5 veterans in it. And so we were willing and able and more than happy to see those patients. In a big, as I said previously, in the previous testimony, in a large group, you probably have the revenue to keep you going when VA didn't pay you for 6 months. If you're a small surgical group with 2 surgeons, as Dr. Benishek may have been, or you're in a small internal medicine group, 2 or 3 doctors or family practice, and you don't get paid along those other payers that are paying less than they used to, you shut the door. You lock the door and go somewhere else. So anyway, I just wanted to make those statements. I agree with most of the things you've said, except I think, Mr. Fuentes, I think there's a way VA, and I think the VA is moving to a different payment system, which will be better for veterans and for the doctors and the providers out in the community. So with that, I yield back.
Thank you. I had one more question, Mr. Fuentes, and that was about your statement about somebody going to the outside the VA to get a care like the ophthalmologist or the eye doctor. Then that patient was then transferred for appropriate care elsewhere, but then the VA wouldn't cover that other physician. How should they fix that? Do you have any suggestions for that?
Yes. So, like I said before, VA needs to treat all the providers within its high-performing network like it would a provider within a VA clinic. So essentially, if I go to if I need to go to an ophthalmologist and receive a specialized treatment, and then have to go to another clinic, I shouldn't have to wait a month for VA to authorize that care, right? It shouldn't be authorization-based. Essentially, just like when I go to an ophthalmology clinic at VA, they're authorized to treat me and provide whatever care I need without having to go back to my primary care doctor and request authorization.
Right. All right, thank you. Any other questions?
Mr. Chairman.
Well, thank you for your participation. Truly appreciate your input. Feel free to, get hold of us as time goes by, to provide more input, because we certainly want to hear what you all have to say. So you are all excused. I'll ask unanimous consent that all members have 5 legislative days to revise and extend their remarks and to include extraneous material. So without objection, that's ordered. This hearing is now adjourned.